Hi everyone, good evening. Dr. Amin here from Toronto. We're going live tonight with Dr. Susan Bryan to talk about GLP1s and all about medications, what they do, some of the good results and some of the questions that you have. We received so many questions, but do not hesitate to drop any questions you have in the comment or the question bubble, and if we had a chance, definitely will answer some of the questions. So we're going live from Toronto. I wait another minute before I invite Dr. Bryan here. So glucagon-like peptides, the new medications, not that new, they have been with us for the last 2 decades, and amazing medications, and started by using them for diabetes type 2 and now for management of obesity. And interestingly enough, we have them and we produce them in our body. This is a hormone glucagon-like peptide that in response to eating our gut produces, and it then signals to our brain to stop eating, we're full, and also signals to pancreas to produce insulin and slow down digestion. Very interesting. But then 2 decades ago, scientists managed to make the medication for management of diabetes. So let's go and find Dr. Bryan.
Hi there. Can you hear me okay? I can't hear anything. Let's see. Okay, can anyone hear me? Hmm. See, I should be. You should, can you hear me? I can't hear you. I cannot. Look, sounds like maybe people can hear me, but I can't hear you. Okay, online people can hear. Hey guys. She's gonna work on her audio. I hear just static, so I'm not sure. Okay, looks like it's thinking and working.
Hello?
Oh, there we are. Okay, good. I got you now. Hi there.
Hi.
Okay, sounds like everybody else can hear us. Okay, so that's good. Hi. So, and
Hi.
I'm in Topeka, Kansas. So I'm in the Midwest, and you're in Toronto, Canada, right?
Yes. So is it 8:30 p.m. where
It's
you are?
7:30, 7:30 Central Time.
Ah, okay.
Yep. So a little bit earlier for us. Yeah.
Yes. So nice to meet you finally.
Thank you. Yeah. Thanks for inviting me. It'll be fun.
Lovely. It is, I'm sure. We received so many questions. So,
Yes.
the first one, let's just dive
Okay,
into some
sounds
of
good.
these questions. That one is, interestingly enough, these medications I see as well in my practice. Some people respond very beautifully and they start losing weight, but then some people don't.
Right.
Barely
Okay.
respond. So is
hmm
this something related to their genetics or
Yeah.
gut
So there's
health or hormones?
Yes, yes. So we think probably two things are happening when you aren't losing weight with GLP-1 medications. One is that you might have more metabolic disease and need a higher dose. So what often happens is in people with, for example, type 2 diabetes or more severe obesity, that the smaller doses are not effective for them. And so we will increase, if you're on semaglutide, for example, we'll increase slowly to that 2.4 milligrams. If you're still not having an effect, then we switch over typically to tirzepatide, which is about 5 milligrams would be about the equivalent of 2.4 of the semaglutide, and then we start going up on the tirzepatide. So patients with type 2 diabetes, more severe obesity, tend to need higher doses. So one part of that can be like metabolic disease, why you might need higher dose. And then the other part of that is we think receptors can down regulate, they can change. Some people might clear the receptors more quickly. So for some people it may not be a metabolic thing, but it might just be more to do with the receptors, and so they need more or different for the doses. So typically going up on the dose, and then if you've reached the max of semaglutide, or you can start with tirzepatide because you can get to higher doses of tirzepatide. So that's one part of the question. And then the second part of that question is kind of similar, but is where people feel like it stops working. So
Mm.
the question came in, and I hear this a lot. I feel like it was initially helping my appetite, but now my appetite is back. Or another question that came in was like, why is it no longer working at a year? And so my best explanation of that is that when you start losing weight, your body wants to return to the higher weight. So it starts putting off more of the, appetite hormones. So it increases the appetite hormones and it decreases the satiety hormones. So it becomes harder to lose weight, the smaller that you get. So sometimes we do have to increase the dose then, because the body naturally is ramping up those hormones at higher levels. And then of course, as you decrease and get smaller lean mass, then you don't necessarily burn as much. Your REE changes and lowers a little bit, and so then you're not necessarily burning those same amount of calories. So sometimes we will increase the dose. Sometimes we even add other anti-obesity medications. So it's not that the medicine stopped working. It's just that your body's mechanism to try to come back up on the weight is very strong. And so then we sometimes have to figure out increasing the dose or changing the type or adding another medicine to it.
Mm-hmm. And what typically you add on which of these medications if needed?
So definitely depends on the person. Once you've gone over to the tirzepatide or start on the tirzepatide, we can keep going obviously on that dose to 5 and 7.5 and 10 and 12.5 and 15. And you can add, if you're seeing a lot of insulin resistance, metformin is technically considered another anti-obesity medicine. So sometimes we'll add metformin onto that. If it's around menopause and there's a lot of menopausal symptoms, that can start tripping up the weight loss because you're not sleeping as well, you're having maybe joint pain, fatigue, maybe anxiety, depression things. So that might be, there are 2 studies now that looked at adding hormone therapy with semaglutide and hormone therapy with tirzepatide, and both of those are just observational. They're not big studies, but both of those suggest that hormone therapy plus GLP-1 in the midlife transition is maybe doubly good, that they can maybe work together. And estrogen does improve insulin sensitivity. So we don't think of it as a weight loss medicine, but depending on the situation clinically, if it's indicated, then sometimes it is the thing, oh, I'm feeling more like myself. I'm getting better sleep. My joint pains are better. I can be more active. So that's another option. And then there are other anti-obesity medications, Wellbutrin, sometimes depending on, what depression status is, et cetera. There's phentermine, a bunch of other anti-obesity that you can also consider. Another thing that I definitely find is that like therapy, thinking about mental health things, sometimes getting at those roots also can help kind of once we get past some of that stress and life issues. So there's a bunch of different things depending on the person that might need to be added or changed to help things be more effective.
Mm-hmm. Great. Yes, I totally agree. I do sometimes add on Contrave, the
Yes,
low dose
Contrave.
naltrexone and Wellbutrin.
Mm-hmm.
Although
Yes,
a lot of people not tolerating it well, so
yes,
we then have to stop. But a
yes,
few. And what about your thoughts on the oral types of the
yes.
GLP-1s and
Mm-hmm.
um, What do you think about those?
So
And
there's
you mentioned there's a new one is coming up
Yes,
too.
so that's right. So oral semaglutide is the only oral GLP-1 that's on the market, and that currently is only Rybelsus indicated for type 2 diabetes. But before the FDA is the request for oral semaglutide for weight loss. And so that likely will get approved probably before the end of the year. That's what people are thinking. And then there's also higher oral semaglutide. And so higher than the Rybelsus. The highest Rybelsus dose we have for diabetes is 14 milligrams.
Mm-hmm.
They're trying to get 25 milligrams, which is even more powerful for obesity. And also, there's more research with small molecule GLP-1s, and that's orforglipron is the one that's furthest in research. That's in phase 3 research right now, and that is different. So the GLP-1 molecules that we have on the market right now are all large molecule GLP-1s. So like Rybelsus, oral semaglutide, you have to take on an empty stomach and you have to wait before you eat or drink. It's a little bit more tricky. But the small molecule that's in phase 3 research, you don't have to do any of that. It's easily absorbed because it's small, it's easy to make. There's no cold storage issues. So it should be cheaper to ship and to store for the pharmacies. And so the hope is that it is easier to take, that it'll be cheaper. That's the hope. And another option of something else that we could add to the regimen.
Mm, great. So yeah, we hopefully looking forward to so many new and better quality.
Yes, there are
And
multiple GLP-1 type, of medicine in this group on right now in research. Another really exciting one is Maritide, which is a once a month injection, and it is two GLP-1 molecules on the base of an antibody against GIP. So, tirzepatide, Mounjaro, Zepbound is GLP-1 plus GIP, both receptor agonists. This one actually antagonizes GIP and is a GLP-1, and it seems to be so far just as effective um, as like tirzepatide, but it's once a month. And what they're showing is that because it's once a month, it has a long
Mhm.
half-life that you can be off of it for several months and still maintain the weight loss. And also in the studies coming up, what they have planned is to do intermittent dosing as part of the research, so that it might even be something that once you reach your goal, and this is what they're actually looking at in research, that you might be able to take every other month or every third month. So that's also really exciting, that in research coming is some more alternative possibilities for maintenance. That's the goal of that, is really maintenance
Absolutely.
dosing. So that's pretty exciting.
Yes, it
Yeah.
is. The maintenance. So again, another common question that comes up is, should we stay on these medications? Some people are worried about stopping and then regaining all the weight. Is this physiologic or is this behavioral problem?
Right. Yes. So there's been several studies that have looked at this, and probably about 2/3 of people regain the weight after a year of being off of the medications. So not everybody. Some people actually continue to lose weight off the medicines. Some people maintain the weight loss off the medicines. So it's not everyone. And they've also done other studies which have looked at what to do when you go off, like bridging the therapy with other anti-obesity medicines. So if you use like the Contrave,
Mhm.
Wellbutrin, the Metformin, other things, and don't just kind of stop at cold turkey, then that can help maintain the weight loss. If you taper it, there was another, I think it was a Dutch study where they did a lot more slow taper off, and they did better maintaining. But really, the problem when you go off these medicines is appetite. And that's what, people will tell you all day long. When I go off the medicine or when I miss a dose or whatever, I feel that appetite coming back. And that's the thing. That's what we talked about initially. Your
Mhm.
body is trying, dang it, to return to that higher weight. It's like So those appetite hormones, you go off the medicine, they start going. And so that's the thing that makes it difficult. In my experience, the people who don't have as much to lose, and when they lost it, they started exercising more, they changed their lifestyle, they maybe addressed some underlying mental health things, their life changed a lot, they're more likely to maintain it. But patients who have lost a very large amount of weight, who had maybe a lot of underlying metabolic disease, um, and already were doing all of the right things before the medicine, they have more trouble, in my experience, not regaining the weight because they were already doing everything right. It was the medicine that really helped make the difference. And so those patients often need more long-term therapy. And that's when, and that was a question that we had too, that's when we start thinking about, okay, what dose is it going to take to maintain your success? And what I have really seen is that patients find that out pretty quickly. And so what I try to do is get patients, and usually often we have to be kind of more aggressive as far as not using it as intermittently or whatever when we're trying to get to our goal. But once you're at your goal, your blood pressure, your cholesterol, your weight, whatever it is we're trying to treat, your A1C, once we're at our goal, then I try to say, well, let's think about what, maybe slowly back off on the dose, maybe do it a little bit more intermittently, go to maybe 10 every 10 days instead of every 7. Like, let's figure out what's the minimum that we need to maintain the benefit. And the majority of the reason we do that is because of cost, So
Yes.
mostly we're doing that because of cost, because really long term, so far, we have mostly just seen benefits of long-term use. Lowering of 10 types of obesity-related cancer, lowering of diabetic kidney disease, chronic kidney disease, heart failure, heart attack and stroke. So, and maybe there's going to be hopefully some dementia, Alzheimer's data coming out this fall. It's not out yet, but so mostly we're just seeing a lot of benefit from long-term use. The negatives that I would see for long-term use, definitely cost, especially right now. And then nutrition. I mean, making sure that you've got your nutrition on point, because you can take these medicines and eat terribly, So making sure you're getting your fruits and vegetables and whole foods and, fiber and protein and all of that. And then, of course, getting your exercise, so doing all of those kind of right things so that you have a healthy weight loss long term. So, if you're doing all of those right things, there's really nothing that we're seeing to this point to say it's bad to be on this long term, just mostly benefiting of it.
Exactly. I totally agree. Interestingly enough, last few weeks, I have seen few patients who wanted to come off medication, especially worried about the eye issue and the blindness. So if you don't mind to tell us a little bit about the scare that people have about this issue.
Okay. So what some studies have shown is that using semaglutide or tirzepatide, probably it's a class effect, GLP1, but semaglutide is the main one, which is Ozempic or Wegovy. NAION is what has been reported, and that is kind of like an eye stroke. So some studies that started last year when a small group of eye specialists reported that they were seeing more of that in patients who use semaglutide. And so they wrote a paper on it. Since then, there's been a lot of different papers looking at it. And some studies have shown an increased risk, and some studies have shown no increased risk. The studies that have shown the increased risk, though, the risk of people who didn't use it was 0.02%. So, and the patients who did use it was 0.04% chance. So you're talking and now technically that's a doubling of the risk. Technically. But if you look at your actual chance, if your chance is 0.04%, it's pretty low. And the other thing, one of the other questions that came out, when I posted this was, does microdosing or lower dosing affect that risk? We really don't know, because that's not been reported in patients who are not using it with obesity or diabetes. And that's the other important thing to understand about the eye blindness or NAION is that having the patients who are on these medicines in these studies have a higher baseline risk of NAION, of eye blindness, because the risk factors are like type 2 diabetes, obesity, obstructive sleep apnea, all, lots of reasons that people are taking the medicine. So it's very hard to parse out if it was the medicine or if it was the underlying risk factors. But even if it is true, which I believe it probably is true, but
Mhm.
still the risk is maybe at the worst 0.04%. So,
Mhm.
I mean, I don't want eye blindness either.
Yes,
But if you're thinking about all of these amazing benefits, especially if you have these issues, and then this very, very tiny risk, everybody has to
Mhm.
weigh the risks and benefits when they're doing the medication. But when you actually understand the numbers, you're like, oh, well, this major thing in the media is actually like takes me from 0.02 to 0.04% chance. Like that's pretty little.
Mhm.
So yes, it might be true. And the mechanism we think maybe is like a lowering of blood pressure. But we don't know if it's related to dose. That's not been figured out in the studies yet.
So these
Um,
people were on the highest dose
we don't
when,
know.
okay, so we
But
don't.
they were on it, and they were on it for diabetes or obesity.
Yes, yes.
So we don't know, they
Mhm.
haven't reported in the studies if it's related to dose, if they were on a higher or lower dose. So those are things we don't know yet in the literature. I
Great.
personally have never seen a case of it.
I have
And I
not.
and I have a lot of patients, and I've seen a lot of patients research too. So, but it is something to be aware of,
Yeah,
and it might be a reason you wouldn't want to take it. Just
exactly. I had
taking
a
it,
few patients,
yeah,
which is absolutely fine.
yeah,
So it's their choice,
right,
anyone's choice. Yes.
right.
Absolutely right. That's great. Very insightful. So you mentioned about microdosing. So if you explain exactly what microdosing means, so because it's
Yes,
so many different confusion I can say about this
yeah.
microdosing.
Yeah, there's a lot of questions. We got a lot of questions
Yeah,
about microdosing. This is a very hot
exactly.
topic. Okay, so microdosing means, in essence, that you're not taking it as it was researched. So
Mhm.
when we do research on these medicines, we have a specific, you start at this dose, and then you go to this dose, and then you go to this dose. And those end up, not all of them, but a lot of those end up being the approved doses. So now the doses that we have for these different medicines on the market came from those research studies. And we use pretty similar doses in the research studies so that we can say it decreases the risk of heart attack and stroke in this population. So once you don't use the medicine at the dose or the frequency that it was used in the studies, then that's considered microdosing. So whatever is lower or less frequent than what we used in the studies, we say that's microdosing. And that just means you're using you're using a smaller dose or less frequent than what we researched it at. So the reason that I think this is controversial is that, you can't scientifically say that this medicine lowers the risk of heart attack and stroke and kidney disease and all of this in a micro dose because it hasn't been studied that way.
Mhm.
But you can say it's lowering your blood pressure, your glucose, your weight, whatever. You can definitely say that. And we definitely see that in microdosing, but it has not been researched that way. So scientifically, we cannot say that. And so that's the issue, I think, is that people say, oh, you can have X, Y, and Z effect. But you couldn't make that like scientific claim. We can definitely say that if you have obesity and you're taking this dose, then yeah, we saw that in the study. So we could say that would lower your risks. But that doesn't mean it's not beneficial for you at a microdose.
Mhm.
You just can't ascribe those same things. So what I like to say, people are taking it, and a lot of people on maintenance are taking some form of microdose often because they're trying to save money. In my experience, that's the most common reason people are microdosing because they can't afford it, at the higher doses every week. Or they don't need that high of a dose anymore. You know, they have, and they've lowered the dose. They don't need it anymore. So they're able to maintain on the lower dose. So, so that's kind of the thinking behind microdosing. And so the question is that the big question is like, well, should people be on it or not if they don't have diabetes, if they don't have obstructive sleep apnea, if they don't have heart disease, if they don't have obesity? And that we don't know. We don't know. That's just not answered by the research. We do know that, for example, patients with diabetes at a lower BMI that aren't obese have the similar benefits cardiovascularly, but those patients still have diabetes. So you still can't say, you can't apply it. But what I tell my patients is like, well, look at your cardiovascular risk factors. Your blood pressure is better. Your glucose is better. Your waist circumference is
Cholesterol.
better. Exactly. So you could infer that most likely your cardiovascular
Mhm.
outcomes are going to be better, but you just can't say that like based on research. I hope
Mhm.
that makes sense and
Yeah,
answers that.
it does very much. That was a great explanation, and I hope everyone has their answer now. What about there were a lot of questions about compounding,
Oh yeah.
compounded versus pharmaceutical. So any danger to it, or should they go by brand? So any
This
explanation?
is this is dangerous territory to comment on because there's a lot of people with very strong opinions about compounding. We compounding was allowed by the FDA when there was a shortage of tirzepatide and semaglutide. So that's how compounding became so common with these medicines because there was a shortage for a long time. But as of this year, the FDA now says there isn't a shortage, and so now says that you're not supposed to compound anymore. So I don't order compounded GLP-1s. I order the Lilly Direct is the most common thing that I order because you can get 2.5 milligrams a month, 4 vials for $350. And then patients can do a lot of different dosing with that, although that is off label. But that's the cheapest. Or you can get Wegovy for $500 a month. So tirzepatide, Zepbound, Mounjaro is more effective at, lower, similar, equivalent doses for cheaper because you can do the 350 dose. So I do a lot of that. And that was a question, how can I get it without, insurance covering it? You don't have to have insurance coverage for Lilly Direct or Novo Direct. The physician or the provider orders it directly from that pharmacy. That's not compounded. It is the FDA product. And so that is how I do. And the thing about compounding is that, you know, it's not supposed to be happening anymore per the FDA because there isn't a shortage. So now I know people do compound still, and they have reputable compounding pharmacies that they use, but that's not what I'm doing.
Exactly. And then a question about anxiety and seeing some even in my patients, I've found out that with binging disorder, eating disorder, they are taking these medications. So any thoughts on that? What are your thoughts? What do you do with the patients? It's not purely contraindicated, I think, but again, how to deal with the patients who have
Yes.
eating
So
disorder.
initially, there were some reports that suggested there was increased risk of suicide on these medications, anxiety, depression. But then a lot of research has come out since then, some really good meta-analysis, which has shown overall, for all of the weight loss medicines, these medicines are actually the least likely to cause those symptoms. And for all the diabetes medicines, this was in a couple different studies, these medicines are the least likely. And in fact, a lot of people feel like they have less anxiety and depression on these medicines. So overall, the studies would show that it doesn't increase suicidal risk. And overall, if anything, it might help anxiety and depression. I have seen that. But there are definitely patients who cannot tolerate it and feel like anxiety or depression worsen on these medicines. That for sure happens. And then either we just don't use these medicines, or we try to treat the anxiety and depression separately, and then see if we can add back these medicines, lower dose, less frequent, really kind of this micro dosing strategy to see if we can get them to tolerate. So there are definitely people who have worsening those symptoms, but the majority of people in the studies, and certainly that's my experience too, actually often feel better on these medications. Binge eating, it can be great for binge eating. I have multiple patients who have improved their binge eating, just countless, and that is often seen. And that's probably the same mechanism how it can help patients with alcohol addiction, drug addiction, that sort of thing.
Mhm. Yeah, dopamine
Yes, that's
working
exactly
on
right.
yes.
That's right. But that might be the same mechanism by which some people feel worse because it's
Mhm.
suppressing that reward center. And for some people, that then applies
Jealousy.
generally. Yeah.
Yeah, so again, always I say to everyone, definitely do these things under practitioner care, doctor's
Yes.
care, and never do it on your own,
Yes.
buying them online and start them. There's always some risk to any type of treatment, including GLP-1s.
Yes.
And then, yeah, we mentioned about the HRT and GLP-1. We answered that question too, and I've seen it in practice with my patients. It works beautiful when they are on both. It works even better. They feel good, great, lots of energy, and then weight loss together combined
Yes,
together.
and one of the questions was, which do you start first? And usually when I
Um,
have a new menopause consult or, weight consult, I try to tease out what is the thing that's bothering you the most. And then depending on that, just changes my strategy because I definitely like the stacking idea of like starting one, the thing that's the most bothersome, getting that at goal, then adding as we need to, because that helps with side effects. And also sometimes you do this and then you don't need anything else for a while. Things are
that's
going so
true.
great. So
Yeah,
I like to say we have a lot of things in our back pocket or on our tool belt, and we can pull them out at different times, use them
exactly.
together. Yeah,
Yeah,
so many
so
things we can do.
very personalized, yeah, approach. I totally agree with that. And so we discussed that. What else? Any thoughts, or have you seen any problems, any complications with treatment of GLP-1s and gut health or gut microbiome
Mhm.
imbalance, or as we say, it's
Yeah.
leaky gut? So any issues after using these
There's
medications?
there is actually some studies showing that some of the autoimmune GI disorders can improve on GLP-1. So kind of interestingly, thinking about gut health, some things autoimmune wise might actually improve. But you absolutely have to work on gut health when you're on these medicines because you can have such a low desire to eat that you stop eating all the good things, all the healthy things. And so that is where fiber, and that was another common question was, what do we do about constipation?
Mm,
Fiber is your friend always. And ladies, fiber is like such a good friend to you. And 30 grams a day, track what you're taking. And in fact, at the Menopause Society meeting, they just presented how Mediterranean diet actually can help sleep in menopause, kind of interesting. And
mm,
one of the ways that the biggest way they think by this research was through gut health. And the most important part of the diet that improved that gut health was increasing vegetables, fruits, and legumes. So, like fiber.
exactly.
But a lot of times if you're not doing much fiber, which track it because so many people actually have really low fiber and they don't realize it. You really do have to work on fiber because if you're not being intentional, it's probably low. So 30 grams is actually quite a bit if you're not aware. But you don't just like go from 10 grams a day to 30 because sometimes that can stop you up. But tracking it and then slowly every week or every day start increasing. And that is one of the best things. And I also like fermented stuff. So I'm a big kombucha, kimchi, all those positive things are great. If you're on these meds, it's a great time to be working on your gut health for
Mhm.
sure.
Yeah, so we see a lot of constipation, as you mentioned,
Yes.
a lot of heartburn and nausea. Sometimes it
Yes.
wears off after a few weeks, but some cases it's quite resistant. So what do we do with those?
There's actually, I don't remember the name of it right now, but there's actually a product that our ENT doctors have been recommending to a bunch of people. And then one of my nurse practitioners started recommending it to GLP-1s, and it's for patients with acid reflux. And it's some type of seaweed product, kind of strangely, but it coats, so it's all natural. Doesn't have iodine though. They've taken the iodine out, but it coats the esophagus and stomach. And so and I've had patients on it now, and they're like, this works really well. So I can put that in the comments below if
Yes.
you post this. But
Very
that's
interesting.
something to try. And
Mhm.
so a lot of patients report I mean, it's very natural. It's not taking an acid reflux medicine or anything like that. And that's what our ENT doctors are now using a lot. It's kind of cool. So now we've been recommending it. So there's something you can try.
I know. Very interesting. I'm interested to know.
Okay, I'll post it below.
Yes. And then yeah, so they're asking, can we continue taking these forever for good, the medication GLP-1s?
So far, that's what we believe. And so far, we believe that probably the benefit for for people that really need these medicines probably outweighs any risks because the benefits are so great.
Exactly. And then supplements. Do you supplement patients when they're taking these medications just to prevent nutrient deficiencies?
Yeah, that's kind of a tricky question, just because there's a lot we don't know about the supplement industry.
Mhm.
I personally don't. I do like to try to make sure patients have, some type of multivitamin that they are at least every other day. And then other than that, trying to get that protein in, which sometimes they need protein kind of supplements, if you will, in the diet for that, as far as, you know, different shakes or protein
Mhm.
powders or whatever. Collagen, possibly, but those aren't things that I routinely recommend. Mostly it's just this kind of fiber, water, protein, Mediterranean, because then we know that's a heart healthy diet. And then if you feel like there's nutrient deficiencies, for a lot of people doing like a regular multivitamin every other day, that's what I do, just to, fill in any potential gaps. A lot of times every other day is plenty because they have a lot of vitamins in there. But then if there's any concerns about that, getting your vitamin levels, you can easily do with your doctor. You can get B12, get vitamin D, get iron, ferritin. There's a
Mhm.
lot of you could do, especially if you feel like there's some nutrient deficiency. So yeah, we
Mhm.
check vitamin levels plenty if there's any concern.
Exactly. And also people who possibly had pancreatitis or a mild version of pancreatitis, not
Okay.
a big one,
Mm-hmm.
not the full-blown picture, just the mildly amylase and lipase elevated and a little bit of abdominal pain. Um, so should they continue with this medication if we think this was because of GLP-1s or
Yeah.
semaglutide, or what do we do with these
I
patients?
have, if you look back in my reels, I have a whole thing on pancreatitis. There was just a paper recently about this.
Mhm.
Cleveland Clinic, endocrinologists at Cleveland Clinic published this saying so many people who've had pancreatitis are being denied these medications that would actually benefit from them. And I personally also denied many patients for GLP-1s that would have benefited from them because I was scared of pancreatitis in the early years. And now I actually have a lot of patients who've had pancreatitis who are now on these meds and have never had it again. There was
Mhm.
actually a study also published about patients with diabetes who'd had pancreatitis previously and went on these medicines and didn't have it again. That is very tricky, though. That is something, if you've had pancreatitis, you've got to work with a specialist
Yes.
on this because that is something you've got to look at. And Cleveland Clinic, this paper, it's such a great review. But they talked about just looking at those risk factors. Is it because a lot of times it's gallbladder? If you lose weight, you can have gallstones. Gallstones can cause pancreatitis. So there is a link in that way. So don't lose weight as rapidly. Look at if you're having any of that right upper quadrant stuff, get a gallbladder evaluation. Consider removing the gallbladder. They had a great review of this. So it's definitely not a straightforward question. But look at that Cleveland Clinic review. That just was this year. It was so excellent. So it's complicated. Work with someone who knows what they're doing, but it's definitely not an automatic no.
Mm-hmm. Great. And last question, we
Okay.
just to talk about thyroid again, that's another question that lots of scare people.
Yeah.
By now, I think many people now understand, but if you would be kind enough to
Yeah.
tell us a little bit
Yeah,
about
so the
that.
thyroid cancer thing is probably way overblown. I have never seen a patient get thyroid cancer on one of these medications. It's not the no, the normal thyroid cancer we're not seeing. That's like papillary, follicular. We're not. There was one study out of France that suggested maybe that was increased. Nothing else has ever shown that. Medullary thyroid cancer is the type that you potentially could get, but we've really just seen that in animal studies. That comes from a C cell hyperplasia. We don't have very many C cells as humans in our thyroid compared to those animals who got it. So the medullary thyroid cancer is very rare thyroid cancer. You know, I have plenty of patients with medullary, but it's a rare type of thyroid cancer. So that is, so technically, if you've had medullary thyroid cancer, you shouldn't be on it. If you have MEN syndrome, multiple endocrine neoplasia syndrome, which runs with medullary, then technically you're not supposed to be on it. I have several patients who've had medullary thyroid cancer who are on these medications because they don't have any evidence of medullary thyroid cancer now.
Mhm.
They are greatly benefiting from these medications, and we're watching for medullary thyroid cancer. So that is probably way overblown, but that is kind of, you know, that the label still says you shouldn't take it if you have medullary, and obviously you should be working with people who know what they're doing with medullary, but you know, it comes from animal studies basically.
Okay, so that's good to know. And one last question is about there was in the questions progesterone.
Oh
So
yeah,
women who are taking HRT worried about
yeah,
endometrial support protection
yeah,
was on GLP-1. So
yep.
that's a
So
little bit tricky. Yeah.
the British Menopause Society had a statement in the past year that said if you take a hormone replacement therapy, you may not absorb your progesterone, your oral progesterone, as well when you're starting a GLP-1 or when you're increasing the dose. And that I think it's even more important to say if you're on oral contraceptives, if you're starting a
Exactly.
GLP-1 or if you're increasing the dose, it may not be as effective. So use another form of contraception. The only reason why we say when you're first starting it or you're increasing the dose is because that's when the GI side effects happen more often. So there's not good evidence showing that
Mhm.
that's happening, but it is a possibility. So if you want to be extra careful, what British Menopause Society said would be double your progesterone dose the month that you start the GLP-1 or any month that you increase the dose.
Or maybe using it vaginally or have Mirena coil. I don't know.
Or have a Mirena with IUD with progesterone, or have an ultrasound that looks at your endometrium if you're
Yes,
concerned about endometrial cancer.
exactly.
But I don't think it's something that's commonly being done, but that is what the British Menopause Society recommended, with
Very
not a
good.
lot of research showing that, but that is something to know about. I think even more important that you know about the oral contraceptive potential risk of getting pregnant.
Mhm. Any other things and issues you want to address here
No,
for
there's
the
thank
viewers, something that we're missing and
no,
it's
no.
very, you know,
I think that, you know, I've had such great experiences with these medicines. I've seen in my life it change many people's lives. And so my main reason of trying to advocate for it is, I mean, I there's risks in to everything that we do, including these medications. So I'm not trying to say there aren't risks. All medicines have a risk.
yeah, of course.
But the media, for some reason, has so overblown so much of this, and I have so many patients that just they get judged by everybody and told, you know, scary stories, and we don't do that with other medications like
Mm,
we do with this medicine. So I'm just trying to put out some scientific information and just be, you know, open and what the research is showing. So
yeah, I love your platform is so good,
thanks.
very informative, everything. So
Thanks.
it's very good. I love it.
Thanks. I appreciate it. Well, thanks for the chat. Have a good night.
Thank you.
Okay.
Thanks, everyone.
Bye,
See you
everybody.
soon. Bye
Bye.
bye.